Hey, good day, everybody, and welcome to another episode of the OIG Roundtable. It's the OIG Roundtable today because I've got Jaysen Eisengrind, retired senior executive from HHS OIG, retired UPIC West director, and currently serving as our special director in charge, special projects for Advise, Matt Kochanski, Jaysen's counterpart, also senior executive from HHS OIG, retired, went on to be the director of the Northeast UPIC, and is now one of our managers, directors on our SIU team. Matt and Jaysen, Wade is busy on a project, so he's unable to make it. So today we've got actually a special guest. It's someone that I've had interaction with for years and years and years, Gary Cicio. Gary is a podiatrist by training, but a fraud and SIU guy by career. Gary and I have crossed paths for 20 years on a variety of podiatry-related cases. And Gary is now working in the consulting field, and we're going to be relying on Gary's expertise going forward on some of our granular podiatry cases. Gary, I'm super excited to have you here. And tell everybody, give everybody sort of a snapshot of your resume. Why is Gary Cicio here today?
All right. Thanks, Eric. And thanks for your other two colleagues. I'm a podiatrist, as you said, by trade, 41 years in clinical practice at this time. I was board certified in 1989, so I'm 34 years board certified in foot and ankle surgery. I obtained my certified professional coder degree in 2009, so I'm also a CPC, now emeritus because I don't keep up my credits, because I'm really not in using this kind of degree or certificate on any regular basis. I was medical director of the year for NHCAA in 2013. I've worked for Empire first as a consultant, then I was hired by Empire, eventually was acquired by Anthem, and now Elevance Health. I put in 29 years in SIU program integrity. And for about 10 or 12 years, I was the consultant to CMS Jurisdiction 13 in New York, which was also included New Jersey. And I supported their SIU projects.
And we're just going to let everybody know that Matt is, he's outnumbered by having three New Yorkers. And so hopefully Matt will be able to understand any of the accents that come up, and we'll gladly provide translation services or subtitles as needed. And Matt, it's okay. We'll consider you a New Yorker for the purposes of today's discussion. So don't be afraid. We're all going to be okay. So Gary,
get a word in edgewise.
Yeah, you might get a word in edgewise. So Gary, I want to start, you and I have had a number of conversations. I post frequently on LinkedIn. Matt and I did a LinkedIn Live a couple of months ago on podiatry fraud.
Sorry, I missed that.
Yeah, and we're going to talk more about some of those LinkedIn Lives in the future. In my career as an OIG agent, I think I did about a dozen or so criminal podiatry cases and a bunch of civil cases. We still see cases coming up. There are a bunch of new schemes that are out there. You were in this field for a long time. You really are a subject matter expert on this.
I've done 13 trials myself.
Yeah, and you've forgotten more than most people know in the podiatry fraud, waste, and abuse space. Tell me, what makes the field, and look, there's fraud in all fields. So we don't want to say that we're picking on the profession of podiatry. But, in 2017 or 2018, a trade publication for the podiatry field wrote a lengthy article in which the trade publication itself identified the fact that podiatry was a known area of fraud, that CMS had its sights on it. The OIG has done a number of studies. I've done a number of cases on it. Tell me, as someone who's kind of on the inside in this profession, what are some of the areas that rise up to, why is there an issue in the field of podiatry when it comes to fraud, waste, and abuse? Not taking away the fact that there is fraud in all sectors of healthcare, but what is it about your profession particularly that gives you pause?
Well, I'll tell you, I think historically, podiatry as a profession has been viewed by the allopathic medical community, MDs and the DOs, as sort of an allied healthcare profession and basically a non-essential service. when I say it's not essential, I mean, we do a lot of really great work in limb salvage, saving people from amputations and such. But those same services can be done by other professionals that are non-podiatrists, like orthopedists can do foot surgery. Dermatologists can take care of foot-related skin disorders. Vascular surgeons can also help reperfuse limbs and also prevent limb loss and wound care. So there's sort of a podiatrist is kind of a catch-all, but it's with a limited scope of practice: foot, ankle, leg, sometimes hands in certain states. But if you go back in history, and podiatry grew up as an office-based surgical practice because no hospitals let podiatrists on staff. I mean, it was almost unheard of. When I came out of school in 1981, it was unheard of that podiatrists were on staff. Forget about New York. I mean, Lenox Hill Hospital, Mount Sinai, it's absurd, no, impossible. As a matter of fact, I was one of the first people that got on staff in New York at St. Barnabas Hospital and then in Long Island College Hospital. But it was the exception and not the rule. And across the country, it was even worse. The other issue is to point to a podiatry as being potentially non-essential was back in, I think, 85, I believe, Governor Mario Cuomo, subsequent to Medicaid Special Prosecutor Edwin Kuriansky's investigation into this big shoe scam in New York, where podiatrists were scribbling out prescriptions for shoes at an unbelievable rate. Mario Cuomo simply eliminated podiatry from the Medicaid rolls. You could not bill Medicaid as a podiatrist. So I think all those things kind of point to the fact that podiatry services that are sort of exclusive to podiatry are considered routine foot care. You know, trimming of nails, cutting of corns and calluses, which are things that other allopathic medical doctors usually do not address, but they're also mostly uncovered for the healthy population. And if they are covered in the diabetic or the debilitated population, they're reimbursed at a low rate. So you have to have an enormous volume in order to sustain a practice, a staff, supplies, pay back your student loans, and your malpractice, which can max out right alongside the allopathic medical providers. So you really can't expect young practitioners. As a matter of fact, I think Edwin Kuriansky himself said he feels bad for the young practitioners, but he can't condone stealing. And right. So I think it kind of, podiatrists will look for ways to maximize income, whereas some of the more allopathic professions and specialties don't have to search that deeply. They're going to probably make a reasonable income by being even reasonably honest, even if you dabble in the gray areas.
Sure. Yeah. And, I think one of the challenges, and I've blogged about this, and Matt and I have talked about this on our LinkedIn Live broadcast. We talked a little bit about the fact that it really is on the Medicare side, and for the most part in the commercial world, a limited benefit. I mean, you brought up that great point, which was how New York State at one point it wasn't part of the defined benefits for Medicaid recipients. And in New York,
correct. And we worked for years.
And in New York, we worked a lot of cases with the shoe inserts, where it was a Dr. Scholl's insert, but it was really being billed out as a custom orthotic. And we had a whole bunch of those cases where that was the case. And yeah, when they are reimbursable, they're reimbursable at very low dollar amounts. And people who come out of podiatry school still have large debt from, it's a medical school. It's not like you're going to, it may be a subspecialty practice. It may be considered,
like a dental school just teaches you dentistry. It's a very focused area of education, but it is in fact a medical school, and they expect pretty hefty tuition.
Right. So Matt, I want to go to you because, one of the things that, you and I have spoken about pretty frequently has been some of these schemes that are out there. And, we identified a few in our LinkedIn Live. We talked a little about the skin grafts, but I just want to go back to you. Let's talk a little bit about the things that you would see when you were at the UPIC and maybe some of the things that we're seeing now, on those skin grafts and those foot baths.
Sure. Yeah, we had a lot of projects at the UPIC, and I'm sure Jaysen did as well, that centered on podiatry. A lot of it was the routine foot care that Gary talked about, and it was the trimming of the toenails, but billing for other things, or disguising the condition of the patient, saying they have a covered diagnosis when they don't. But one of the projects that came up recently had to do with the skin substitutes and the skin grafts, where we ran a lot of data, and it showed just a huge spike in podiatrists doing skin grafts with very large wounds in the feet, and it being the first remedy of avenue of remedy rather than trying other things first. And with CMS, we were able to do almost like a data-driven overpayment for a lot of these podiatrists on these things, and it was very easy for the UPICs to do, and it was surprising at how quickly it spiked up, and from where we don't know, but it just really was a huge boon to our return on investment. And then there was also we didn't do a lot of the baths, the foot baths, but I know that was a large scheme as well, where they were billing for things that weren't even water soluble to be put in the foot baths to
Correct. It's the antifungal agent.
Yeah, and it was just seemed it's impossible medical services.
So Gary, are those
easy to testify at, because as you said, if a substance that your doctor is telling you to soak your feet in warm water isn't even soluble in that water, I think that's something even a jury that sometimes are easy to confuse are going to understand that that's simply not therapeutic.
So Gary, do you, when you hear about these kind of schemes, and I know that you've got some information about some other schemes that are out there, but when you start to see these schemes like the skin grafts, and the foot baths, which are a huge dollar amount because it's typically warm foot soaks 2 or 3 times a day with a half a dozen different lotions, potions, ointments, and creams that aren't water soluble, that are super expensive. Is this the morphing in the podiatry field? Is this the morphing from the scams of yesteryear, which still kind of exist, of things like circumventing the 60 or the 61-day rule, depending upon how you look at it? Is it the 61st day or is it the 60th day? The rotation of the codes for people that would get medically necessary services for routine foot care because they've got the Class A, Class B, or Class C findings. And because SIUs, Medicare, the UPICs, the OIG, because everybody is kind of familiar with those schemes, are the skin grafts and the foot baths sort of the next iteration of what podiatry fraud beholds? I don't know the better way to put it, but is it kind of like, is it like fraud 2.0?
It kind of is in the instances you just gave. In the 1980s, the foot bath scheme that was prevalent was billing hydrotherapy, Whirlpool. Whirlpool on routine foot care cases, so you get Whirlpooled every 2 months because you'd come back to soften up your corns and calluses, and they billed that as hydrotherapy. Again, it didn't pay a lot but it's just an added service charge, and physical therapy or hydrotherapy administered every 2 months is not therapeutic. It's a foot bath. It's not hydrotherapy. But that has morphed into the 2000s as being a much more lucrative foot bath scheme because of all the expensive medications that are prescribed to be used in these soaks. So yes, it's morphed, it's changed, and far, far more lucrative. But what I've always told people is podiatry and again, skin grafts is new, because skin grafts in the 80s were almost unheard of, except for your taking skin from one part of your own body to putting it on another part of your own body, and maybe porcine pig grafts and such. But there's innumerable number of skin substitutes now. Many companies, at least on the commercial side, have policies that will pay for some, not pay for others. CMS, I think, is very lax in their LCDs and NCDs when it comes to all these specific products, because they're just gaping holes that are being taken advantage of. And whereas Matt had mentioned about skin grafts on very large foot wounds, it has morphed into more using skin grafts on any kind of wound. Even if you do a nail surgery, they'll pack it with some sort of skin graft, because the nail surgery might cost, or might pay $125, but the graft could pay $1,000. So it's just these add-on charges that are superfluous. They're medically unnecessary, but they're often not caught and they're paid. I'll give you one quick example. We had a podiatrist in California who had previously lost his license for sexually molesting a 14-year-old girl. How he got it back, I have no idea, but he did. And he billed us over a $1.2 million, I'm saying $1.2 million paid on eye grafts. Mm-hmm. Amniotic grafts to the eye. And of course, it's our fault. We paid it. Right. He refuses, we're in negotiation now, he refuses to pay it back. And it's just this, stonewalling game, because any code that begins with a V like in victory, it's a HCPCS code. This one was V2790, which would be a good thing for all of you to take a look at if you have data mining teams. V like in victory 2970, that's an amniotic graft, but it's an amniotic graft to the cornea. If it's done anywhere else, you can't use V2790, but he did, and we paid.
Right. And that's an interesting point, because that really goes back to the discussion about how the data analytics are only as good as the things that we can tell the tool to do, right? Correct. So it's the pay and chase continues, right? So now if you've got, in that instance, the oddity is, well, the podiatrist's NPI is showing that their service ID is basically podiatrist. In the Medicare world, I think it's 48 is the professional service, right?
That's so where Medicare is good. They actually will block certain services to specialties that should not be performing that service. Right. Commercials are way behind in actually doing that. They're coming along. Obviously we've changed our shtick over at Anthem based upon this $1.2 million loss, but it's not as intuitive as you would think it would be.
Right. Yeah, and that becomes the challenge. And on a future podcast, you and I are going to spend a lot more time talking about a case called Jamaica Foot Care or Citywide Foot Care, and we're going to talk about hydrotherapy, which is exactly what they were doing as an add-on code for people that were getting what would have been otherwise unreimbursable Medicare services for routine podiatry that they were getting, where they were throwing in the hydrotherapy. But
right.
So Jaysen,
that was just the tip of that iceberg.
That was just the tip, and we'll that's a whole separate bit of time, because we don't have forever. We could talk forever about that case. But Jaysen, so I want to go to you, because one of the things, as an OIG leader, but then also as a UPIC director, is ensuring that you've got the right experts helping you when you're doing trial prep. And, I know you had a number of trials when you were an OIG agent, and there is nothing that is more important when you are preparing for a trial, but also during your time at the UPIC, where you're putting cases together for referrals, is the importance of having an appropriate expert to help with that navigation. So talk a little bit about that and how that interplay works. Like, why are the Gary Cicios of the world important on the SIU fraud, waste, abuse piece?
So first, I'd like to, just for Matt's benefit and any other non-New Yorkers that might be listening, a shtick is a modus operandi. So, but anyway, so once you identify the scheme, you have to assess what consultants might be needed to support proving that scheme. So, it goes back to like the three major types of investigations are billing for services not rendered, some sort of product substitution or upcoding, and then medical necessity. A service not rendered do you necessarily need a specialist that can identify the service? Probably not, because the service wasn't rendered. So, maybe in that circumstance, a specialist may not be needed. But once you get into product substitution and upcoding, and definitely medical necessity, you've got to fight fire with fire. So certainly the very competent medical director that we all enjoy on our various contracts can do many services that might be done by a specialist that is a podiatrist. However, fraud in this century is a lot different than in the last century, and they're getting much more sophisticated and prodding very specific areas that specialized information is going to be needed. So you have to identify those specialists. Another specialty area, and most SIUs and definitely OIG and UPICs have the specialists on data analysis, because this is a perfect example. Podiatry services are a perfect example of where they're generally, not always, but generally lower dollar claims, but high volume. And to Dr. Gary's point, many podiatrists aren't generally on staff at hospitals. So what happens is podiatrists are harvesting patients at places like skilled nursing facilities and congregate care facilities, senior living centers. And so the volume is there to support their return on investment of providing those services, because it can generate that high volume. So to investigate those types of allegations, you really need to be very much involved with the data analysis. You need to think about sampling and extrapolation to be able to get a return on investment for that investigation.
Jaysen, I'd like to add one thing about just a comment about when a service is not rendered. You mentioned that it may not need an expert. Well, I actually had a case where I was brought in as the expert witness because there was a doctor in Philadelphia, actually in suburban Philadelphia, that was billing in an enormous number of surgeries on patients, like 3 or 4 surgeries at each encounter. To the point, my point being, his attorney was arguing that the patient who's going to maybe testify, the patient doesn't know what the doctor's doing. The doctor's the expert. So if the doctor says he did a nail bed repair, how is the patient going to know if his nail bed was repaired? So in that particular case, they actually had an undercover agent go in with a briefcase that had a camera in it. I saw 4 or 5 and reviewed the entire each encounter, and of course I wrote it up for the special agent in Philly. I don't know if anybody knows Christian Sondergaard, but in any event, most of my write-ups said to a high degree of medical expertise, I can say that this service was not performed, and in some instances I could say to 100% medical certainty these services were not performed. So you didn't have to rely on what an attorney would point to as an unreliable patient that doesn't really know what's happening.
Well,
Totally
and Gary,
agree. And I just like to say one quick thing is that I totally agree, and that's why I had that little caveat in there, because everything is its own situation, and you certainly found where that would be necessary. Thank you.
Yeah.
and Gary, as we again, Matt, sorry.
I'll say one of the things we did at the UPIC is a lot of the states required that we had specialists within the field and licensed in that state actually do the medical reviews. We found ourselves using them as well as consultants on cases beyond just the medical review, but working with the investigators on what to look for, perhaps going out on interviews with them and things like that, so that we had these in-house cadre of consultants that we used.
Yeah, I did a case out in Boise, Idaho, on a podiatrist that was raping Blue Cross and Blue Shield of Idaho. They're 2 separate companies out there, and they have like 93% of all the business in the state. He was robbing them blind, and he was actually on the board of podiatry that sat in judgment of other podiatrists getting licenses in the state of Idaho. And so they couldn't find anybody to testify against this guy. And so they grabbed me.
Yeah. So yeah, these are important points, like having that expertise. So Gary, we're kind of running out of time, but I wanted to circle back both a little bit with what Jaysen said, Matt said, and you said. We're talking about this service is not rendered, and I know we've talked about this before. Is the topic, the issue of nail avulsions, where
Right.
I've worked a number of these cases where the provider billed for nail avulsions, on 15 toes. The last time I checked, unless you've been in some sort of a birth defect or an industrial accident, not wearing steel-toed shoes, you only have 10 toes. But the thing about nail avulsions, whenever I would get a podiatry case, one of the first things I would do is I would data mine for nail avulsion, CPT code, because that to me was, while I do agree that a patient may not know what they had. Did they have, if a podiatrist billed for mycotic nails greater than 5, 11,721 versus 11,720, does the patient know that? But a nail avulsion is a surgical procedure requiring anesthesia, a sterile field, bandaging, antibiotics, follow-ups. If you had a nail avulsion, typically you're going to remember these things.
Right. It's sort of like if you go to a dentist and get a cleaning, you might not remember how many cleanings you've gotten, but if you go there and have a root canal, it's probably going to stick in your mind.
Right. So there are some things, and we talk a lot about it in the SIU space, that podiatry cases are typically great cases for new investigators and new agents to work on, because the traditional fraud schemes, and we're not talking about some of the more esoteric ones, the skin grafting and surgical, and I know, we're not going to really have time, but there's a whole issue involving anesthesiology. But, these kind of run-of-the-mill, I call them run-of-the-mill, but traditional frauds. There's an NCD that's pretty clear. There's an LCD that's pretty clear. There's policies on these things, that these are good new agent, new investigator type cases. But
and I'll give you one extra that you may not be familiar with. One of my biggest cases early on at Empire Blue Cross Blue Shield was, we called it the PINS project. That's involving surgical K-wires. If you fracture a bone surgically and you reposition it, you run a K-wire through it. Well, historically, podiatrists used to leave that K-wire sticking out of the skin with a little cap on it. It would be incorporated in the bandage, so you couldn't catch it on anything. But 4 weeks later, when the bone had knitted together and you don't need that pin anymore, they would pull it out and bill it as a surgical excision of pin. But that's not a surgical excision at all. And it's included in surgical aftercare by both CMS and almost every commercial carrier I know. So they would bill it under multiple levels of complexity for removal of hardware or removal of foreign body. It depends on how creative they get. So there's a whole series of those codes I can send you guys as a follow-up, because I know we're running short.
Interestingly enough, in the ophthalmology world, the removal of a foreign body is a common ophthalmology fraud scheme, when they will claim that they're removing an eyelash or a foreign body that doesn't exist. Patient will come in complaining of feeling a sandy feeling or eye irritation. So, so we're running out of time. I want to give you the last comment, and that is, where do you see the field of podiatry going in the next few years in the fraud schemes? Do you think that there is going to be an abatement of the fraud schemes in the podiatry world? Because there's so much of it with respect to the skin grafts, the foot baths. Where do you see the field turning a corner? We've kind of seen some fields, like, in the cardiology world, we've seen some corners being turned with things like stent placement in the cardiology world. What do you see going on with podiatry?
Well, I'll just say one thing. Fraud in general is cyclic. Although there'll be new fraud schemes as new CPT and creates new codes, so you have to learn those codes because they didn't exist before. So maybe they'll be abusable in the future. So we can't predict that. I think podiatry in general is getting better as a profession because the training is better, the residency training is better, the surgery is better. there's less need to scheme on the end of surgery, but there's always going to be fraud, and fraud is cyclic. If you stay in this business long enough, let's say I'll say every 10 years, you're going to see the nail avulsion scheme come back. You're going to see the PINS project come back. You're going to see people that bill for a removal of sutures as being a removal of foreign bodies. I'm sure the skin graft schemes will evolve with the creation of new new graft, new skin substitutes. So do I see it turning? I think it's going to get better, because I think the people are being trained better, so they won't be so stretched to make money. But I don't think it's going away.
Yeah, and it's interesting you say that, the cyclical nature. I've always said on these podcasts that we do that the circus stays the same. It's the clowns that rotate, right?
That's
because
correct.
you start to see some of these schemes, and when you read the press releases out there from the different U.S. attorneys' offices around the country, you can see these fraud schemes that go on where it's kind of the same thing. I talk a lot about how the COVID era fraud schemes involving telemedicine or telefraud, they were going on years ago with diabetic testing supplies and things of that sort. So it really is this, this recapitulation. So Gary, as always.
Well, the other thing I was just going to add is that if you're in this profession long enough, and I was in there for almost 30 years, like I said, I picked 10 years because people retire, people pass away, people move to other geographies. So if you're an astute investigator, I would keep a log of all your cases, or the specifics of the case, because 10 years from now, if you're still doing this with your same company or a new company, you can look smart all over again, because you can rediscover what you discovered a decade ago.
That might be the best advice that I've heard in a long time, and honestly, it's a great takeaway for this. So, Gary, listen, this was great. We could talk for hours about these fraud schemes and how they morph and all these different things out there. And we'd love to have you back on for something where we can spend a little bit more time. So it's been great having you on. It's great reconnecting with you, and I look forward to the next time that we can speak again. Matt, Jaysen, as always, great having you guys. Good seeing you. For those of you, again, that do not get our newsletter, feel free to reach out to us. hello@advise, ADVIZE health.com. Send us an email. We'll get you on our newsletter. You can also get our podcasts, our LinkedIn Lives as recorded events on our YouTube channel. Just go to YouTube, look for Advise Health. You can subscribe to the YouTube channel. You can get all of these recorded podcasts, the LinkedIn Live, all of the other content that we've got. So until next time, we'll see you again. And thanks again, as always, for supporting our podcasts and us as a company. Take care, everybody.
Thanks, Jaysen. Thanks, Matt. And thank you, Eric. You have a great day.
Gary.